name's Aysha. I'm one of the ST5 Rheumatology registrars at Worthing Hospital, and today I'm going to be presenting the skin that told the story, from incidental skin rash to acute respiratory failure. So today I'm going to be presenting the case of a 74-year-old lady who was being seen in the dermatology clinic for excision of a squamous cell carcinoma from her nose. However, she was noted to have a rash on her fingers and chest. And after dermatology follow-up in several clinic appointments, she was referred to the medical team for assessment of possible dermatomyositis. She had reported a dry cough, as well as shortness of breath and a reduced exercise tolerance from someone who was very active to just being able to walk around short distances. She had some muscle stiffness but no weakness, and had also reported some sicker symptoms. On examination, she had some skin changes consistent with Gottron's papules, as you can see in the image here, as well as a V-neck sign and shawl sign. MMT8 was unremarkable, and her observations were stable with no oxygen requirement. Investigation showed a mildly elevated CRP, and a chest X-ray showed bilateral reticular changes with lower zone patchy opacification. The HRCT was done to investigate this further and showed probable non-specific interstitial pneumonia and organizing pneumonia. Her CTD screen later came back positive for anti-52 antibodies, and an extended myositis panel later revealed her to have MDA5 positive antibodies. A malignancy screen as part of the dermatomyositis workup showed an incidental nerve sheath tumour in the infratemporal fossa, which was discussed in MDT and was for active surveillance only. Initially, when she first presented, she was started on prednisolone 40 milligrams. However, following the results of her HRCT scan, she was pulsed with IV methylprednisolone for 3 consecutive days. Despite this, her condition rapidly deteriorated and went from not requiring any oxygen at all to requiring high-flow nasal oxygen, with difficulty maintaining her saturations and desaturating on minimal exertion with oxygen. A repeat chest X-ray 2 weeks into her admission, and despite the IV methylprednisolone, showed worsening bilateral infiltration. She was urgently discussed with the tertiary centre and was transferred across for further management. On arrival to the tertiary centre, she was then treated with IV cyclophosphamide and also commenced on tacrolimus. She was successfully weaned off oxygen and does not require any long-term oxygen therapy at home. She has now completed 4 cycles of IV cyclophosphamide and is being assessed for maintenance therapy, with a view of starting on mycophenolate soon. She is now able to walk 1 hour and can even manage a short run with a bus. So this case highlights the importance of early recognition and MDT input for the management of MDA dermatomyositis, which is a life-threatening condition and can have rapidly progressive ILD with irreversible lung damage and can even lead to death. This patient presented with classic dermatological signs and was fairly stable initially, and had these signs been missed, her admission may have been delayed further. She had rapid deterioration despite IV methylprednisolone, and this highlights the seriousness of this condition and the importance of having intense treatment regimes early on. So just to show you some images, this is her admission chest X-ray where you can see some bilateral changes, and this is her HRCT scan, which shows bilateral ground glass changes as well as changes consistent with NSIP and organizing pneumonia. And this chest X-ray here shows the 2 weeks after admission and shows worsening of lung changes despite the treatment with IV methylprednisolone. It was at this point that she was transferred across for the IV cyclophosphamide. So to summarize the key learning points, so MDA dermatomyositis is an amyopathic form of dermatomyositis. It is a rare condition and is also life-threatening. Early recognition and management is crucial to avoid permanent damage and reduce the mortality risk. Subtle dermatological signs in a seemingly stable patient may be early features of a serious systemic disease requiring urgent management, and this highlights the importance of a thorough clinical examination. MDA5-associated ILD can be aggressive despite initial treatment with steroids. An MDT approach is required, including discussion with tertiary centres when appropriate. And finally, dermatomyositis can be associated with malignancy, and therefore a basic and enhanced cancer screening may be required depending on the patient's risk and antibody profile. Thank you very much.